Alright, so my presentation was over triangular fibrocartilage complex, or the TFCC. So, what is the triangular fibrocartilage complex? It is a structure that is made up of cartilage and ligaments and is located on the ulnar side of your wrist. What does it do? It stabilizes the bones in your wrist, acts as a shock absorber, enables smooth movements of the wrist. Some of the anatomy. So the TFC is the triangular fibrocartilage discus, and you have the radial ulnar ligaments, the ulnocarpal ligaments, the meniscus homologue, the ECU tendon sheath, and the ulnar collateral ligament. So the pathology for a TFCC injury would be a sprain, a strain, a tear of those ligaments or the tendons that make up the structure. The mechanism of injury includes a falling on an extended wrist with a forearm pronated or fooshing, excessive radial deviation, a distraction force applied to the forearm or wrist, a distal radius fracture, distal ulnar fracture. Some of the signs and symptoms include pain on the ulnar side of the wrist after a fall or a direct blow, point tenderness at the back of the wrist, increased in swelling when bending the wrist sideways, swelling, clicking sounds while performing movements of the wrist, a decrease in your grip strength, and then weakness and instability of the wrist. Some of the special tests that we talked about in class would be the TFCC compression test. It would also be Sharpie's test, the ulno-meniscotriquetral dorsal glide, the supination lift test, and the press test. Some of the predisposing factors are really anyone can get the TFCC injury, but athletes who use rackets, bats, or a club are more prone to this type of injury, and also athletes who put large amounts of pressure on the wrist, such as gymnasts. And this is also degenerative injuries are more common in people over the age of 50. And then if you have any previous history of fractures, you could have any congenital abnormalities, and then using forceful twisting or pulling motions. So management and treatment of TFCC injuries include non-surgically, so that could be a splint or a cast, non-steroidal anti-inflammatory drugs or NSAIDs, a cortisone injection, ultrasound therapy, cold therapy, or RICE, so rest, ice, compress, and elevate. So continuing with management and treatment, if surgery is required, it is usually on severe degenerative injuries or large tears of the TFCC muscles or tendons, or if there's any sprucing or torn pieces of cartilage that are in that area. And also if the ulna is unusually long, they'll shave off the distal end of the ulna to make room for those muscles and ligaments. And then referral and immobilization. So initially it can be assessed by the athletic trainer, but then referral to a physician for imaging and examination. And then if surgery is required, you'll be in a cast or a dressing. Usually a heavier dressing is used for immobilization. And then if non-surgically, you can use a splint that can be worn anywhere from 4 to 6 weeks to completely immobilize the area. So prevention, there's not really a whole lot of prevention for this. You can avoid falling on an outstretched hand. So if you do start to get pain, you can just use a simple brace to avoid any further stretching of the tendons or ligaments, and then just knowing your limitations and your strengths. Some of the differential diagnoses for TFCC injuries would be an ulnar styloid fracture, flexor carpi ulnaris tendinitis, ulnar carpal impingement, or widening of the distal radial ulnar joint space. And then mulligan technique. So there is a mulligan for a TFCC, and you would start the taping at the anterior ulnar styloid and pull laterally on the dorsal side to shorten the length of the muscles and ligaments of the TFCC. That would all be an anatomical position. And then there are also multiple classifications for a TFCC injury. Class 1 would be a traumatic type injury. Class 1A would be a central perforation or a tear. Class 1B would be ulnar avulsion with or without distal ulnar fracture. Class 1C would be distal avulsion. And Class 1D would be radial avulsion with or without sigmoid notch fracture. And then we can go into Class 2, which would be degenerative. So Class 2A would be a TFCC wear or thinning of the muscles and ligaments. Class 2B would be TFCC wear with lunate and or ulnar chondromalacia. Class 2C would be TFCC perforation with lunate and or ulnar chondromalacia. Class 2D would be TFCC perforation with lunate and or ulnar chondromalacia and lunotriquetral ligament perforation or tear. And lastly, class 2E would be TFCC perforation with lunate and or ulnar chondromalacia, lunotriquetral ligament perforation, and ulnocarpal arthritis. And this is my PICO analysis. So there were 46 volunteers, 21 male and 25 female, with a mean age of 30.8 years old, who had no pain in the ulnar wrist, and then they had 46 TFCC patients, 22 male and 24 female, with a mean age of 35.5. The wrists on both group underwent magnetic resonance imaging, or an MRI. So T1 would be normal, T2 would be multiple cracks, T3 would be changing intensity of tendon, S1 would be normal, S2 would be effusion in the sheath, and then S3 would be disruption of the sheath. There was no comparison. The outcome, so for T2, which is multiple cracks, in pathology in the patient groups, for T1 there were 29 of them, for T2 there were 50, for T3 there were 20, and that was significantly more frequent than in the volunteers, which would be 39, 4, and 20. And then surrounding pathology, S2 is significantly more frequent in the patient group, so S1 was 35, S2 was 11, S3 was 0, than in the volunteer group, which was 40, 4, and 0. And those are my works cited.